Hi, everyone, and thanks for coming today. It's wonderful to be part of a forum on reflection, because I think that's an incredibly important aspect of remaining whole as emergency physicians. I'm talking about diagnostic reasoning, which I've been interested in, I guess, my whole 30-year medical career. And I guess what's evolved out of that, it's common science now, so that all of you should be familiar with the terms. And in this 20 minutes, I'll only be able to touch on concepts, but is this too essy? I'm just trying to move it away from me. No? One of the things that I'd like to imagine is that every department would have a diagnostic reasoning champion who might look at these ideas for a model to underpin case discussions when they come up, because I think that case discussions and reflecting on and abstracting from concrete experiences and then thinking about how we'll approach the new one is how all of us learn the most effectively. Those case discussions really get the amygdala working, and the opportunity to mind map allows everybody to contribute and see where one's individual black holes might be and how one might change one's practice and think about it because of the multi-dimensional aspect of diagnostic reasoning and providing best care for families. So the concepts that I want to touch on, even if you just take some of that vocabulary away, I think mind mapping is an important concept, and there's reasons for that that are neurophysiological, and that we can do that both in terms of our own, say, note-taking or even thinking about it during a resuscitation. It comes from dual process theory, which has everybody heard of? Yes, which is just that idea of the logical left brain and the analytical right, the intuitive, so to speak, right brain. We'll look at the ways in which those work. It's important theory to underpin it, but I don't want that to take away from some of the fun of the talk. I want to talk about the concept of the best problem formulation and how critical that is to how we think about diagnostic reasoning, and how that should be a continuously evolving thing, and how we need to make sure that all of us in a room or working on a case have the same best problem formulation, and if we don't, how we can get there. I want to talk about the necessity to always zoom in and out, both in terms of your affective relationship with the family and also in terms of the actual patient, in terms of examining them, so that you're always seeing big picture, big picture, and then really small picture honing in on the what they call the key features. The importance of uncertainty and holding a space for that uncertainty. Affective awareness and becoming aware in your body. I'm interested both in being aware in your body of the patient's body, but also being aware of in your body of what red flag feeling is, and of what the feeling of anger, or you just you believe that there's such and such there and you just want to get them out of the room is, because when those feelings are rising, it's time to do what people are starting to call a cognitive stop, or a cognitive nodal point. I want us all to be very clear in our mind the difference between right answer and right reasoning, and the fact that we should be aiming for right reasoning, and doesn't matter whether we get the right answer, because the right reasoning, so long as it's shared properly, will lead others to the right answer. The differences between odds and stakes, just the concept of Bayesian analysis, which has gone out of vogue, but which I think we're actively doing all of the time and is very important. What arborization means, theoretically, a binary decision between two things that you have 100% certainty about, but how important it is to identify what those critical arborization branch points are when you're in a diagnostic dilemma, and also getting back to really how we get a better understanding from a family when things are complex about what's wrong, and also how we communicate what we think is wrong and how we think it should better be approached, understanding that patients sit within an illness representation framework. So illness has a meaning and symptoms have a meaning for a family, and the words that we do intersect with those meanings. And unless we have a very get as good an idea as we can of what the patient experience is, which of course is Michael's expertise, then we won't be able to help them at all. So just this idea about mind maps, and there is lots of software available to help people do these now, and I've started using one called Mindomo. But anyway, one of the reasons when I was learning anatomy in second year, I started realizing that I couldn't learn from the textbook because it was a whole lot of words. I really had to learn from atlases. So I ditched the textbook and I always learn from atlases. And it's probably partly because I'm a visual learner and you can do online questions about what type of learner you are. But they also recognize that learning from text is a two-stage process. First you absorb the words and then you organize it into relationships and categories and all the rest of it. And a mind map does that for you already. I think the other thing is that I'm sure a lot of you will relate to the idea that many people who work in emergency medicine have an ADHD personality type, and I certainly do. And the short-term working memory is actually smaller in people with that typing. And the mind map can help take the place of some of that and helps us to remember things better. So I actually do use a mind map, and I do use mnemonics during resuscitations, not necessarily trauma ones, but particularly if they involve altered conscious state or seizures of unknown cause, because they help two things. They help me to gain a collective mind map, which helps overcome my blind spots. They help keep everybody on the same page, and they provide anchoring points for those diagnoses that may be not top of the availability list, but may be very important to think about when things don't always fit. So this is a busy slide, but it's just a mind map of the way in which the structure that I use to underpin somebody else's case discussion. And I guess what I'd like to, best problem formulation, sorry, is in the center of that. And then all sorts of other things are working around that. And what I'd like to say about it just quickly before I move on is that the fascinating thing about what we do in diagnostic reasoning is that a lot of things are happening simultaneously, especially in the emergency department, and time is ruling everything, really, and there are some things in which reaching a time-critical intervention or definitive treatment, this idea of goal-directed therapy, that can become more important than the diagnosis is. So, for example, in a case that Katie and I co-presented, there was a child who came in with the what I call alabaster sign, meaning he was as white as the sheet, and proceeded to vomit blood, and his HB was 2.5 on the gas machine. Establishing blood for him was more important than getting a diagnosis, and then recognizing what were the critical branch points, the algorithm branch points that related to the things that would get the right help for him. And of course that algorithm branch point is related to pathophysiology and where was that blood coming from. So it didn't really matter that he had an obscure disease, lung hemorrhagic disease that I can't even remember the name of. But what did matter is that we got blood into him, established that we were going to need a massive transfusion protocol, alerted people from the various different areas that his blood might be coming from. And one is doing all of those things simultaneously. And also importantly is the back and forth relationship that's occurring between your evolving best problem formulation, the differential diagnosis that springs up in your head as soon as you see a patient. It may only have one or two things in it, or one thing like influenza A, but the back and forth that is going between that and then your response to treatment. So all of those things are going back and forth, and they should be going back and forth in a very flexible way. It's absolutely amazing what our brains are doing through that time. So this is concept, and this is this idea, and some of you have heard me ask this before, of how comfortable people are with grey, with things not being black and white. So just have an idea in your head where 10 is you just got to have things black and white, and 1 is you are just so comfortable in grey, you're swimming in it all the time. So we don't have time to ask you what your individual responses are, but it's a very important question. Because if one of the commonest answers that I've had people, emergency physicians, say is, I'm a 3 wanting to be an 8. And I think one of the things that characterizes emergency medicine is that you kind of like problem solving. I love diagnostic dilemmas, but that's because you have this urge towards turning a grey into a black and white situation. Now, the greater that urge is, the more you're going to fall prey to premature closure, and other errors like that in diagnosis, in which you just really want to have an answer and you're ignoring the things that don't fit. And many great writers, and I must recommend this book, How Doctors Think. I think it's exceptional, and a lot of his stories and vignettes overlap with my own experience over the years. This urge towards black and white is an important thing, and being able to have a nodal stop point when you recognize that there's something that doesn't quite fit. I must say that even though I keep all these things in my mind all the time, the other day I had seen somebody with high fever and swelling in this area. Yeah, I thought of parotitis, and I thought of, lymphadenitis, and I thought of both of those because Cindy told me that in America you can bill more if you write down 2 things in your differential diagnosis rather than just 1 provisional diagnosis. So I've started also because one of the things that people who err towards premature closure and who think of everything as sparrows rather than canaries are supposed to teach themselves to do is to think, what else could this be? And so I thought of those 2 things. But as I was writing up his notes, I had made some comment that the thing was fluctuant. And then I thought, oh, well, can't have been fluctuant because a parotitis shouldn't be fluctuant, and lymphadenitis, if it was fluctuant, would be so extremely sore, which he wasn't. Of course, he actually had a brachial cyst or some sort of malformation, which was indeed fluctuant and not totally abscess-ridden yet at that point. But I think the point at which you're overriding a physical finding with your theory about something is a cognitive stop point, and it's a really important lesson and an error that I'm still committing. So there you go. Best problem formulation is a term that I got from a professor in general practice, but the important thing is this error to do with framing. You know, the error of framing, and how, if a triage nurse which hardly ever happens anymore, or a letter that comes in says that it's one thing, like the cholecystitis who dies of the leaking abdominal aneurysm in your acute area rather than in your resus area. Those are your frames, and your best problem formulation needs to be include all those key features, but not be leading you towards one thing or another, not to be able to go further than it actually is. But it's actually evolving, and it's the key diagnostic starting point, because it defines the umbrella of investigations, and it also defines your mental list of differential diagnosis. And it needs to be joint. And again, I'm thinking of an unconscious child that I saw who at some point during the resuscitation blew a pupil, but this hadn't been communicated to the team, and so parts of the team were holding back from definitive management of his raised intracranial pressure and the need to, with urgency, get him to imaging and to definitive treatment for what indeed was an extradural in a very unusual setting with no history of trauma. But just as an example of how that evolves, this is a child that I saw once who came in from school having collapsed with diarrhea. If you get a little bit more, and that's her original frame, unconscious diarrhea collapse. And then we've got a longer frame that has a respiratory rate. And so in terms of fast forwarding this, the diagnostic dilemma is, the algorithm branch point is this tachypnea metabolic or respiratory or cardiac in origin? And so the next step might include respiratory rate 48, BSL of 50. And once you've got that, you've actually got a diagnosis, not just a best problem formulation, because you've got a diagnosis of DKA until proven otherwise. So that's an example of the evolving BPF. Sorry. Intuitive reasoning, this kind of right brain thing, like it's not really intuition, as we'll discuss later on in this, but it is to do with, it's not like you kind of make this up or just feel something in an airy-fairy way, but it is to do with the number of patterns that you've seen and how you've reflected on those patterns so that you're recognizing it and its variations. The point about it, which emergency physicians love, is that it's parallel processing, so it's fast, but it's difficult, it's individualized, so it's difficult to communicate to others, and it's very influenced by affect and other contextual factors. And it's characterized by this idea of the book Blink, which is, you can read there for yourself. This is from Ornithology, but it's to do with observing a lot of features of something before you home in too close and getting that gestalt for something. And similarly, it's this idea during World War II, this GIS, which is general impression of size and shape, when conditions are too poor to permit positive identification, which is our conditions every day in the ED. So that's that idea of where intuitive reasoning comes from. And it's not just I mean, all of those words that we use like gut feeling or intuitive, they suggest that it's kind of magical. But actually, as Polanyi touches on, it's to do with a lot of other things that come from careful observation and reflection, and it mustn't be underestimated. Zoom we've discussed. This is a physical example of Zoom, but Zoom also relates to how close you get when you're directing a resuscitation, how close you get to an individual feature and your ability to back out of it. And I think the need to be very flexible, like a champion tennis player, around diagnostic reasoning is absolutely critical, and it's a practice that you must learn. The analytical idea, at least, people talked about these as though people did one or the other, but actually we're going back and forth between all of them all the time. And that's particularly, it's arborization with its branch points, it's taking things at a time, and it's really turning over every stone. And it's very important too, as parts of what we're doing, and it involves that binary arborization. But what we have to choose is, what's those branch points in the arborization? What is going to really lead us to what I need at this point in time? And of course, some diagnoses, like, forgive me for not giving you the time, but rashes and illness scripts lend themselves to pattern recognition, whereas others, like abdominal pain, still can be pattern recognition, but altered conscious state, really you have to start to think about things logically, and neonatal jaundice, things that can have so many different pathophysiological origins. We have to have a methodical, step-by-step way of thinking through those things. The role of time is incredibly important, and it's perhaps the most important story of history. So defining what that is in a graph and just having a little idea in your mind of the time symptom curve of the presenting problems that you see and how they differ with different types of diagnoses. Odds versus stakes, the child who comes in with their collar after a rugby injury probably has a high stake, and that's why there's so many people clustered around them. But the odds are very low. So when you're going for your X-ray, you have to know that your pretest probability, according to both past and current studies that we're doing, is about 1 in 1,000 in terms of children who are thought of to possibly have a neck injury and those who do actually have an unstable injury. But the red flags that need to cause those cognitive stop points are where the objective finding doesn't fit, when you don't have the usual entry feature. And this is where, I mean, a lot of this is looked at in retrospect. Why was the extradural missed? Because we didn't have a history of trauma. Why wasn't the MI missed? Because they didn't come in with chest pain. Or a patient has atypical pain perception. So I think when something doesn't quite fit, when the whole thing doesn't add up, remember that you may have the wrong entry point. For example, one of my list of misses was a child with testicular torsion who did not come in with his parents and was from an underprivileged background, and he was complaining terribly of abdominal pain, and he was he was staggering like this. I thought it was because, and he was indeed incontinent of diarrhea, but he wasn't incontinent of diarrhea because he had colitis or because he had renal colic. He did look like he was infarcting, and he was infarcting. He was infarcting his testis. But I also think the point at which you override a decision rule and say this doesn't apply to me, I've seen lots of cases. I haven't seen the 22,000 head injury cases that the Chalice study was based on. So every time you step outside the decision rules, just make sure that you have adequate grounding for that and adequate follow-up for that. Getting to know your blind point. A blind spot is helpful to you, and I did a series of 8 pages, and there's one of my error analyses. And views of the mountain is also important because they build up your total picture. Polanyi, I just wanted to mention because Polanyi is talking about embodied knowledge and the fact that in our bodies we contain all of those things that we've seen, and I stand opposite a patient and examine them, at least observe them in this way. And I think many things are happening. Our right eyes are taking in their left side of the face, which is showing the affect. And I'm also observing symmetry very closely in that way. And I think a lot of things are happening during that we are not aware of because of Polanyi's statement that we know much more than we can actually communicate. There are techniques for reducing diagnostic of error, but only one of the ones that has been shown to use is diagnostic case modelling, which is why I come back to this idea that if we can have a champion that kind of underpin the case discussions that we have with some of the theory and the terminology and the concepts, then we'll teach better diagnostic reasoning. Thank you.
Thank you, Robyn. That was a real whirlwind of a lot of things I think that we all sort of struggle with in our day-to-day practice. Katie, do we have a few questions? We have a minute or two.
I'll just quickly mention that Damien Rowland has kindly shared a few pieces that he's written regarding a few of the things that Robyn discussed, so I'd encourage you to check those out on Twitter. We do have a question from Matthew Barber. Can mind mapping be done interactively with the patient to reach a common understanding?
I think that comment, yes, I wouldn't, I mean, clearly it's not that same map because your starting point from mind map for your conversation with the parents is understanding what life's like for them at home.